Okay, so go on with our conference, and the next speaker is Burda Basnyat. Burda Basnyat is a medical director of Nepal International Clinic, and we planned to have Burda with us here, but unfortunately the rule of the pandemic forced us to invite him only by remote, and we are really sorry for this, but this is the life in these days. Have we any problem?
You can't hear, but...
Okay.
Okay.
Thank you. Thank you very much. Good morning. Can you hear me?
Yes, with a lot of noise. Try to speak again.
Okay. Yes. How about now? Is it better?
Now is better, yes. Yes. Okay.
Thank you. Thank you very much, Annalisa. So yeah, I would love to be where you are, but this is real life. So I this is how things happen. But I want to thank you for inviting me to this conference. And it's always nice to hear people's voice whom I know for many years, and good old Italian friends. So thank you very much. Now, so I help with the Himalayan Rescue Association and also the Mountain Medicine Society of Nepal. So that's the high altitude side of things. But I also do, as Annalisa, wrote to me and said, maybe I could concentrate on or focus on infectious diseases as they pertain to high altitude. I thought about this, and then I said, we have, like, the infectious diseases don't, they do not preclude themselves from high altitude. So I'm going to talk about some of the common diseases that we see here in our part of the world. And so I hope you will find this, it's not exactly like all the time like unique just to the mountains, but it is common in the mountains, and we have to deal with it sometimes probably more often than altitude illness in the local population. So, just to give you an idea, this is Nepal. So we are, the north of us is China, and we're pretty much surrounded by India, as this map indicates. And, it's important just because we have a pandemic going on, just to let you know what is happening in Nepal. So as you can see here, so this is July of 2020. We actually saw our first case in around January or so, but then it sort of took off during this festival season. And then, it went down, and many of us thought that COVID-19 had gone away, and some in South Asia thought that there were a lot of antibodies. But lo and behold, we got that Delta virus. We tracked India, basically, and we got hit very badly. And then, it went down, and it sort of like stayed down. Now, as you can see here, this festival is going to repeat itself here. So we don't know, if there's going to be a lot of replication and mutation and we'll get a wave, but so far it's good. The good news is that we're really getting a lot of the Chinese, the Sinopharm vaccination here, and people wear masks. And they, because as you know, Kathmandu, there's a lot of pollution, and in other parts of Nepal too. So wearing a mask is not a problem in general. So I think maybe that is also being protective for us, because this is, after all, a respiratory virus. And if you wear a mask, obviously it's going to make a difference. So I just wanted you to have a feel for this. I put my key message here right in the beginning. So it's kind of, just to make it different. So climate change is also, so, you know, there's tremendous climate change in the Himalayas, and it's helping to bring some common, I will mention this, common vector-borne diseases, you know, like dengue fever from the plains. So we, as I showed you on the map, we border on India, where, you know, this is very almost sea level. And then, as you know, we go all the way to the hilly regions, to mountain regions, and the climate change is making some of these infectious diseases appear. And some of, you know, at higher altitudes, specifically dengue. You know, and I will also just mention, you know, common diseases for you, almost biblical diseases that I like to say, like tuberculosis, you know, that you treated in sanatoriums, or like typhoid, which you probably have never seen in your life. And, you know, a lot of people in Europe get typhoid mixed up with typhus. They're completely two different organisms, don't all, you know, even respond to the same antibiotic often. And these continue to be rampant. And remember the population of South Asia, you know, this is all the Himalayas, Hindu Kush, this, that. But this is a crowded place. It's got a 25, you know, like, yeah, about 1/4 of the world's population lives here, 1.8 billion people. Just to give you an idea, I showed you that map, you know, like south of us, humanity-wise, there is an America sitting here, because the most populous states in India, Uttar Pradesh and Bihar, they're easily 300+ million people. That's the population of India. So humanity-wise, I mean, we're, you know, like there's a lot of activity for viruses like COVID-19, for dengue, as I will mention. And the sad part is that, you know, we're not making use of vaccinations. For example, we studied this vaccine for typhoid called conjugate vaccine, a new vaccine, a very effective, much more effective than the, you know, the polysaccharide vaccine, but it is underutilized in this 1.8 billion population. Just to give you an idea, just how common are these? What is the burden of disease? You know, so before COVID-19 arrived, just put you in perspective, we thought in Nepal, dengue was going to be our main infectious disease because of its heavy disease burden in the region and the socio-economic impact. We thought there would be a dengue explosion in Kathmandu. Dengue was first reported in Nepal in the southern plains in 2004, but, you know, so Kathmandu is like, so in the plains we had dengue, but it started coming up in 2019 to even at 1,300 meters in Kathmandu in July of 2019. So Kathmandu has become an ideal breeding ground for the Aedes vector mosquito because of climate change. So that climate change is obviously a factor here. But it, you know, together with climate change, it's the urbanization, the haphazard urbanization, the brisk trade and transit from dengue-infested areas, which is from India, you know, and the poor health infrastructure that goes without saying. All of this have led to dengue. And also, you know, like the vector, this mosquito, flies only 500 meters in their life. So if you're packed in, as I was trying to indicate, this 1.8 billion population, and these viruses, as we now so well know with COVID-19, do not require you know, a visa. So if 500 meters in their life in a closely packed population, if that's all they can fly, you can imagine that they will be spreading the disease. You know, so it is with the vector, goes to higher altitude, climate change. So, you know, this is going to be potentially problematic. Many patients with fever, you know, so fever, now in the differential diagnosis of fever in our part of the world, we not only have COVID-19, of course, this is a pandemic, we have to rule it out, but there's dengue, and then I refer to typhoid, typhus, tuberculosis, and they're many times incorrectly diagnosed. You know, because we have old tests. We saw the importance. If COVID-19 has done anything, it has shown the importance of rapid diagnostic, reliable rapid diagnostic tests. And like typhoid fever, for example, that I study you know, there's this old, it's called the Widal test that maybe perhaps some of you read in your medical textbooks many, many years ago. For some of you, maybe not so many years ago. And, you know, it was made over 100 years ago, and we're still using this. This is the most commonly used diagnostic test, which is totally unreliable for the diagnosis of a rampant disease called typhoid fever. Well, how rampant is it? Look, this is a bacterial, it's a non-zoonotic disease, you know, it's human restricted. And look at this, it is about, this is a mistake, I'm sorry, I exaggerated. It's not 5,000, it's 500 per 100,000 population. Just to give you a perspective, some of you may know, anything over 100 is troublesome. So we have 500, excuse me, it's not 5,000, this is a mistake. So 500 per 100,000, we have an effective vaccine, it's underutilized. This is you know, a continuing story. Typhus is a zoonotic illness, you know, sounds like typhoid. A lot of people in Germany, at least where I've heard, you know, they'll be saying typhoid, typhus, again, it gets very mixed up. Very similar presentation to typhoid, and the thing is, not only do they sound similar, and they are have similar presentation, and they use this ceftriaxone drug for fever left, right, and center in South Asia. 1.8 billion population, you know, in the Himalayas, the Hindu Kush. So ceftriaxone is the treatment of choice for typhoid, but our study showed, which we published in Lancet Infectious Disease, that they're very suboptimal for this other rampant disease called typhus, for which the best drug is this humble doxycycline. You know, and people don't seem to use this because people like to give ceftriaxone for fever. So tuberculosis, you know, Annalisa mentioned about tuberculosis and these places for recovery at high altitude, for asthma, and sanatoriums in the old days for tuberculosis. So our incidence, I told you typhoid is 500. So look, this is 250. So this is a lot of people. And my guess is about 20 people die of TB per day in Nepal. I mean, some of these things so we have a pandemic that for us is reminding us that these other things are endemic, but they could be pandemic for us. You know, this is one of the things that I should have put in the key messages. And I feel very strongly we're going to be doing this. We need to, you know, and the WHO has endorsed this, that if we want to meet the TB control target set down by WHO, we in countries like Nepal, India, Pakistan, Bangladesh, where there is this tremendous burden of disease, 250 per 100,000, we need to be not doing just active case finding, but treating latent TB. And we're starting this in Nepal as a, you know, this is what the WHO is recommending. This is not a trial. This is, we want to see how we can implement this in Nepal and hopefully, you know, hopefully in the region. And you know, so you can have, as we all know, in the monasteries in the mountains, people are praying together. Not only is typhoid, you know, there's these bugs, if they're respiratory bugs, if you're in a gomba, if you're in a, you know, this is ideal ground for all of these. You know, wearing masks may be something that in this part of the world should be taken more seriously. So I'm done. You know, I know this is infectious disease, but I just wanted to give you a flavor for how rampant these are, whether you have mountains or, you know, whether you climb mountains or don't climb mountains, or, you know, so this is this and climate change is obviously impacting on this. And I have I'm done with my talk, just some references which are freely accessible. So that we wrote about some years ago, 2-3 years, you know, dengue explosion in Kathmandu, you know, typhoid versus typhus. We, as you all know, had this big earthquake in 2015. People got typhoid mixed up with typhus and many died. Tuberculosis in South Asia. I think this is an Italian journal that we published this in, A Tide in the Affairs. You know, we think this is the moment where, a critical moment where we can do something to help with, you know, tuberculosis, probably, you know, bigger killer than typhoid. These are rampant, but if there's one disease that, you know, we would like to really control is tuberculosis. consumption. And the last, second last, this typhoid conjugate vaccine trial, this might be, so we trialed this, we showed this to be effective, but now we're now trying to, finally Nepal has said that they will use this in their typhoid immunization, in their immunization registry for national immunization program. And we hope that they'll do this in India, Bangladesh. Pakistan is already doing it because they're having to deal with a resistant typhoid H58 Salmonella typhi. So this is being used, this vaccine that we studied, and and just before, thank you. And this is another, so we wrote this in 2017, emerging and re-emerging infectious disease threats in South Asia, their status, their vulnerability, preparedness, and outlook. And we actually have mentioned coronavirus in this, although it's MERS coronavirus that we talked about, because the novel coronavirus had obviously not shown up at the time. But this is something that if you have the time and the inclination, you could consider reading some of these. But I just want to say that that these infectious diseases, that old biblical diseases, have always that we continue to struggle with. And the silver lining with COVID-19 is that it's focused on the diseases that this impoverished part of the world, if you will, just continues to suffer on, and it's almost, as I said, as like a pandemic, although it's in this region mostly. So thank you very much. I went a little more than my time. Thank you. Thanks to all of you, and thank you very much, Annalisa.
Thanks a lot, Buddha. Thanks, because you have shown, you have remembered us that there is not only COVID-19, we are talking about COVID-19 since more than 1 year, but there are many other diseases that can affect humans. So thank you a lot for this wide opening mind presentation. So see you later for the discussion if it's possible. Okay. So